ان شاء الله هنبتدي الجلسه. الاستاذ دكتور احمد مصطفى الجعفري هيكلمنا على البيلشفوسكي تيست Diagnostic Importance والكيس سيريز.
بسم الله الرحمن الرحيم. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. في البداية يعني إنه لشرف لي إن أنا أكون مع أستاذنا وأستاذ الحول في مصر الأستاذ الدكتور إبراهيم العدوي، وربنا يبارك في عمره ويحفظه ويمتعه بالصحة والعافية إن شاء الله. I will talk about the Bielschowisky test. This test was first described by Bielschowisky in 1935 to diagnose the superior oblique palsy. However, later on, it also be used for differentiation between other vertical muscle palsies, obliques, and vertical recti palsies. Most commonly used to differentiate between ipsilateral superior oblique palsy and the contralateral superior rectus palsy. It should be noted that this test is useful for the diagnosis of a single paretic vertical muscle. It is unapplicable for multiple paretic muscles or in restrictive myopathy in case of the thyroid ophthalmopathy. The three-step test. There are three questions must be asked in this test. The first question, which eye is hypertropic? The second, does hypertropia increase in right gaze or left gaze? The third question, does hypertropia increase with right head tilting or left head tilting to the right or left shoulder? Principles and explanation. Let us describe the eye in primary position of gaze. In this position, there is a balance between the elevators and the depressors. So, any disturbance of this balance will lead to the eye will deviate up or down, hypo or hypertropia. For hypertropia, عندنا long differential diagnosis of hypertropia. The time is limited to discuss this point, but generally speaking, if right hypertropia or left hypertropia, we will ask the same three questions. And if the hypertropic eye increase with abduction or abduction, and if hypertropia in the right or left increase with head tilting to the right or to the left. Returning back to this photo and the normally present balance between elevators and the depressors in normal state. In a patient with right hypertropia, when we try to isolate which muscle is paretic, it must be either depressors of the right eye or elevators of the left eye. All of us know that the vertical recti are best tested in abduction and obliques are best tested in adduction. So, on abduction, superior rectus is the only elevator, inferior rectus is the only depressor. And on adduction, inferior oblique is the only elevator, and superior oblique is the only depressor. So in abduction, superior rectus is the only elevator and inferior rectus is the only depressor, and no rule for obliques in this position. And in adduction, also no rule for superior rectus and inferior rectus. So the first differential diagnosis was between four muscles, two muscles in each eye. Now we exclude two muscles. So in this photo, The differential diagnosis will be the right superior oblique, the right inferior rectus, one of the depressors of the right eye, and the left inferior oblique and left superior rectus, one of the elevators of the left eye. What is about the head tilt? When normally in normal state, when I make head tilting like this, the field I see will not go with my head like this, will be maintained in the central position. Why? Because there is a rotation movement of both eyes. The right eye will be rotated as intorsion, the left eye as extorsion. Superior muscles, superior rectus and superior oblique are intorters. Inferior muscles, inferior rectus and inferior oblique lead to extorsion. So, returning back to the 3 questions of the 3-step test. Always look for the hypertropic eye. As we said, we have to define, we are talking about the right eye or the left eye. The first question, which eye is hypertropic? Say, we started to discuss the right. So we will say, the answer of the first question, right hypertropia. Second question, is hypertropia increases on adduction or abduction of the right eye, which have chosen from the first step. Say, there is a right hypertropia and increase on adduction of the right eye. We will go to the third step. Is the hypertropia increasing with head tilt to the right shoulder or the left shoulder? If the right hypertropia increase with adduction of the right eye and increase with head tilt with the same shoulder, with the right shoulder, the diagnosis will be superior oblique palsy of the same or hypertropic eye. If the right hypertropia increase with adduction, but increase with head tilting to the other shoulder, which is the left shoulder, the diagnosis will be superior rectus palsy of the contralateral eye. Why hypertropia increase in case of superior oblique palsy with tilting of the head with the same shoulder? The reason for this is that right superior oblique and right superior rectus, as we mentioned, that the superior muscles lead to intorsion, work together to make intorsion, but the superior oblique is paralyzed. However, in case of right superior oblique, so the elevating action of superior rectus is unopposed and causes increase in right hypertropia مع الانتورشن اللي هو مش بتقوم بيه superior oblique لأنها paralyzed. Among the secondary changes in extraocular muscle following paralytic squint or superior oblique palsy here, overaction of the ipsilateral antagonist. Conclusion: if hypertropia increase on locking nasally, this is the superior muscle palsy. If hypertropia increases on locking temporary, this is inferior muscle palsy. If hypertropia increases on locking nasally and increase with head tilt with the same side, it is superior oblique palsy of the hypertropic or the same eye. But if increase on tilting the head to the other shoulder, it is superior oblique palsy of the other eye. Hypertropia increases on head tilt to the same shoulder, oblique muscle palsy. Hypertropia increase with tilting the head to the other shoulder, it is vertical recti palsy. Case presentation. Left hypertropia, This is step 1 or the first question. Step 2, left hypertropia increase in right or left gaze. The left hypertropia increase on right gaze, nasally or on adduction. معلش 2 minutes بس لو سمحتي. The third step, hypertropia increase on right gaze, increase also in head tilt to the same side, like this photo and like the red arrow. Diagnosis, severe oblique palsy with inferior oblique overaction after surgery. This is before, and this is after. Hypertropia of the left eye, no hypertropia after surgery. On adduction, hypertropia. On adduction, no hypertropia. Head tilting to the same shoulder, hypertropia. Head tilting, no hypertropia. This is before and after surgery. Right hypertropia. And regarding the first step after surgery, no hypertropia in step 1. For step 2, no hypertropia in adduction. And step 3, no hypertropia on tilting the shoulder to the right shoulder. Tilting the head to the right shoulder. This is post-operatively. Thanks for